Welcome to From Literature to Bedside. In this episode, we take on the most feared mechanical complication of colonoscopy, iatrogenic colonic perforation, with particular attention to the perforation that occurs in a tumor, in diverticular disease, and in inflammatory bowel disease. Perforation is uncommon, but it turns an elective ambulatory procedure into an abdominal emergency, and it carries real mortality. As screening volumes grow and therapeutic endoscopy becomes more ambitious, large mucosal resection, submucosal dissection, stricture dilation, stenting, the per procedure rate is falling, yet the absolute number of perforations we are asked to manage is rising. Three principles govern outcome and they organize this talk. First, time to recognition. A perforation closed or operated within hours does far better than one that presents late with peritonitis. Second, the state of the patient and the peritoneum. Stability, preparation, and contamination decide the pathway. And third, the underlying pathology at the site. Malignancy, diverticulitis, or inflammatory bowel disease, which pushes management away from simple closure and toward resection. Consider the numbers. Across more than 10 million colonoscopies, the pooled perforation rate is about 5.8 per 10,000, roughly 6/100ths of 1%. But risk scales steeply with therapeutic intent. Diagnostic colonoscopy around 0.03%, polypectomy around 0.09%, large endoscopic mucosal resection about 1.1%, and endoscopic submucosal dissection about 7.2%, a seven-fold step from resection to dissection. Colonoscopy attributable mortality is low, around 3 per 100,000. But once a perforation occurs, the case fatality is substantial, pooled at about 11%. Three mechanisms operate often together. Mechanical injury is the commonest, shearing from forceful advancement and loop formation, classically against the fixed sigmoid. Barotrauma from overinsufflation raises intraluminal pressure beyond what the wall tolerates and typically produces a thin-walled cecal blowout. And thermal injury from polypectomy or dissection current characteristically causes a delayed perforation, hours to days later. Site follows mechanism. The sigmoid accounts for roughly 53 to 65%, the segment most exposed to looping and the home of most diverticular and neoplastic disease. The cecum, thin-walled and prone to barotrauma, is next. The rectum, only about 1%. And note, the rarer diagnostic perforations tend to be larger, dirtier tears than the small thermal defects of therapeutic work. Who is at risk? Advanced age, a long mobile sigmoid, and prior abdominal surgery with adhesions. Then the diseased bowel, diverticulosis, an obstructing tumor, and inflammatory bowel disease, which carries roughly an 8-fold higher risk. Concurrent corticosteroid use raises that risk about 13-fold. These disease factors are exactly why we will return to cancer, diverticulitis, and colitis in detail. On the procedural side, risk rises with complexity. Dissection above resection above simple polypectomy, and with stricter dilation. And the operator matters. An annual volume below 141 procedures carries almost a 3-fold higher odds of perforation. And non-gastroenterologist endoscopists have higher rates and later recognition. There is no universal classification, but 3 axes drive decisions. Size, small under 10 millimeters, intermediate 10 to 20, large above 20 to 30, predicts whether we can close endoscopically. Mechanism, as we have seen, and timing of recognition, seen at endoscopy, immediate within hours, or delayed up to about 72 hours. Delayed recognition with contamination is the single strongest driver towards surgery. Recognition at the time of endoscopy is ideal. A visible mural defect, mesenteric fat or peritoneal structures, or a sudden loss of luminal distension. Afterward, Perforation declares itself as persistent or increasing pain, distension, tachycardia, fever, and peritonism. A low extraperitoneal perforation may instead present with subcutaneous emphysema, pneumoretroperitoneum, or pneumomediastinum. Computed tomography is the imaging of choice, preferred over plain films. It detects small volumes of extraluminal gas, localizes the leak, and quantifies contamination. But remember, free air denotes perforation, not necessarily peritonitis. The clinical trajectory, not the volume of air, drives the decision. And resuscitation, nil by mouth, intravenous fluids, and broad spectrum antibiotics covering gram negatives and anaerobes begins the moment perforation is suspected. Management converges on three questions. Is the patient stable? Is there peritonitis or fecal soiling? And is there underlying pathology? The answers sort the patient into one of three pathways: immediate endoscopic closure, a monitored non-operative trial, or surgery. Let us take each in turn. When a perforation is recognized at endoscopy in a stable patient with good preparation, no fecal soiling, and a defect the available device can close, endoscopic closure is first line and it avoids surgery in the majority. Success is greatest within about 4 hours before inflammation and contamination progress. And carbon dioxide insufflation is encouraged throughout because it limits the extraluminal gas and the pressure that drive contamination. The devices in brief. Through the scope clips are first line for small defects under 10 mm with clinical success around 90%. The over the scope clip achieves full thickness apposition for defects of roughly 10 to 30 mm with success from 92 to 100%. Endoscopic suturing extends our reach, including to the right colon, though data remain limited. And endoluminal vacuum therapy, a sponge exchanged every few days, is an emerging rescue option for a contained leak. If closure fails or the patient deteriorates, refer for surgery without delay. A monitored non-operative trial is reasonable for the small contained microperforation in a stable patient without diffuse peritonitis or significant contamination and after successful endoscopic closure. It means nil by mouth, intravenous fluids, antibiotics, and the essential part, serial clinical review with a low threshold to escalate. Any deterioration or rising inflammatory markers should take the patient to theatre. Surgery is indicated for the unstable or peritonitic patient, a large or delayed defect, failed or complicated endoscopic closure, frank fecal contamination, or when underlying pathology demands resection. Where hemodynamics and expertise allow, a laparoscopic approach is preferred and is now widely practiced. Reconstruction is dictated by timing, contamination, and the bowel itself. An early, clean, small defect in healthy bowel may be closed by primary suture repair. A disease segment or a defect unsuitable for simple repair calls for resection with primary anastomosis in the stable, acceptably clean patient. And for delayed presentation, gross fecal peritonitis, instability, or poor tissue, resection with a stoma, a Hartmann's procedure, where an anastomosis would be unsafe. Now to the heart of this episode. When there is pathology at the perforation site, the calculus changes. Simple closure is usually the wrong operation. Consider three settings. First, perforation at a colorectal cancer. A friable obstructing tumor is both more likely to perforate and, once perforated, mandates an oncologic resection with proper margins and lymphadenectomy, not a simple repair. This is not only about sepsis. Tumor perforation risks intraperitoneal tumor cell spillage and is prognostically adverse. In a comparative cohort, perforation was independently associated with a markedly worse 3-year recurrence-free survival, about 42% versus 79%, with a hazard ratio near 4.3. Practically, avoid stenting a malignant stricture in a patient on bevacizumab, Handle known tumors gently, and if perforation occurs at a neoplasm, treat it as a cancer operation. Second, diverticular disease. Diverticulosis concentrates in the sigmoid, the very segment most exposed to looping, and it thins the wall. Colonoscopy is contraindicated during acute diverticulitis and deferred some weeks after an episode. When perforation occurs in a diverticular sigmoid, that inflamed segment is rarely suitable for simple repair. Management follows emergency diverticular principles: resection of the affected segment with the choice between primary anastomosis and a Hartmann's driven by contamination and physiology. Third, inflammatory bowel disease, one of the strongest disease-related risks. Colonoscopy in these patients carries roughly an 8-fold higher perforation risk and concurrent corticosteroids about 13-fold. The vulnerable substrate is active severe colitis with deep ulceration and a thinned wall, and fibrotic strictures subjected to balloon dilation, which carries a perforation rate around 0.6% per procedure. Colonoscopy is contraindicated in acute severe colitis and toxic megacolon. And when perforation complicates inflammatory bowel disease, the friable, steroid-affected bowel usually needs resection with a stoma, not a primary anastomosis. A fourth modern setting deserves mention: perforation after endoscopic mucosal resection or submucosal dissection. This is the fastest growing source. Many are small intraprocedural defects clipped at once. The specific hazard is the delayed thermal perforation presenting hours to days later, which current guidelines flag as an area still needing better evidence. Prevention and immediate closure of visible defects are the mainstays. Outcome is dominated by time and contamination. About half of perforations are detected during or immediately after the procedure, and these fare best. Pooled case fatality is around 11% in patients averaging 69 years. Delay, fecal peritonitis, large tears, and underlying pathology all worsen it. And where perforation occurs at a cancer, the oncologic outcome is independently worsened even in the survivor. Prevention then is concrete: carbon dioxide for higher risk procedures and avoid over-insufflating the cecum. Gentle technique and loop reduction, especially in the sigmoid and the post-surgical abdomen. Case selection: defer colonoscopy in acute diverticulitis and acute severe colitis. Avoid stenting on bevacizumab, and avoid dilating a Crohn's stricture with active ulceration or a suspected fistula. And immediate clip closure of any visible mural defect during resection. A word on the evidence. Almost all of this rests on retrospective series and expert consensus. The European Society explicitly declined to grade its statements for want of high-quality studies. There are no randomized trials comparing endoscopic with surgical closure or repair with resection. The thresholds we use, the 4-hour window, the size cutoffs, are pragmatic, not trial-derived. Hold them as sensible defaults, not as proven law. So to synthesize, perforation is rare but lethal enough to respect, about 11% case fatality once it occurs. Diagnose with computed tomography, resuscitate, and give antibiotics at once. If the patient is stable, the field clean, the perforation early and closable, close it endoscopically or observe. If they are unstable, peritonitic, late, or contaminated, operate. And above all, let the underlying pathology lead. A tumor becomes a cancer operation. Diverticulitis and colitis become resections, usually with a stoma. Recognize early, match the response to the peritoneum, and respect the disease beneath the hole. Thank you for watching From Literature to Bedside. I am Dr. Gautam Krishnamurthy. Until the next episode, operate on the evidence.